The healthcare industry is shifting, and it's time to do something different. North Mississippi Health Services is redesigning healthcare, and we want you to be part of it too. Good morning, I'm Shane Spees, President and CEO of North Mississippi Health Services, and I'm pleased to be joined today by Sharon Nobles, our Chief Financial Officer for our healthcare system. Sharon, thank you for joining me this morning. So we're here to talk about the R in a great redesign strategy, and you may recall the R stands for reimbursement. And our focus in a great redesign as it relates to reimbursement is changing how we're paid from our payers, like the insurance companies, like Medicare and other payers. And so I think in order for us to talk about reimbursements, let's talk about why it's important, why reimbursement is important to us, kind of the financial implications of reimbursement. And so when we think about reimbursements and payments from payers, that's our source of revenue for a healthcare system. And so those revenues help offset cost. But there's also a misunderstanding about our organization being a not-for-profit healthcare system as opposed to a for-profit hospital, for-profit healthcare system. And so help us understand the difference between a not-for-profit and a for-profit healthcare system.
Right. Well, we as a not-for-profit clearly have a mission to continuously improve the health care of the people in our community. And one of the ways that we do that is providing service to people and our patients without any insurance at all. And in fact, in FY23, our cost to provide service for uninsured people was over $28 million. In addition to that, as a not-for-profit, we provided uninsured discounts, or basically reducing the cost of care for people with low or no insurance by $51 million. That's different than the for-profits because we honor our mission by providing that free care. But to the point about why we need to actually generate a profit, we have to have that kind of income to make reinvestments in our people, our services, and our technology. Without that profit, we would not have the funds available to make that and continue our mission in providing care.
Right, and so some people may hear not-for-profit healthcare system and think that we cannot make a profit or shouldn't expect to make a profit. But the difference is we reinvest our profits back into people, services, and technology versus a for-profit entity typically has shareholders that they return that profit to. So it's a very important distinction, but the important point there is that we expect to make a profit, need to make a profit so that we have resources to reinvest back in our healthcare system. So let's talk about reimbursement and think about how we're reimbursed by payers today. And a couple of episodes ago, I had a chance to talk with Wally Davis around payers, specifically Medicare Advantage. We talked a bit about reimbursement today, and kind of simply put, we're reimbursed per patient visit or per patient stay or per surgery that's done in an outpatient center. And so our payment is strictly based on the amount of volume of patient care that we provide, not necessarily tied to quality or any cost savings, that type of thing. Right. So, you might well just mention under that fee-for-service model, we call it, paid for volume, sort of how does that work in comparison to a value-based purchasing model that we're talking about today?
Right. Under the current model is called fee-for-service. So you're right, Shane, that we are paid through our volume and maximizing our revenues for the amount of volume that's coming through our system. What is not present in a fee-for-service model is any standardization or any profits due or any income due to quality of care or outcomes. When we compare that to a value-based, the focus is on outcomes, and the focus is on how those outcomes are for the patient, and it is focused on standardizing care, really looking at how that is delivered and really focused on the total cost of that care that's being delivered. So it's a very distinct different, with the incentives vastly different.
Yeah, so in today's time, under the current fee-for-service model you mentioned, that we're paid based on the volume of care we provide, there's really no differentiation among providers in terms of quality or access or service or outcomes with it. You're just paid for making that visit or providing the surgery. versus volume-based reimbursement models would actually pay us for the quality of care we deliver and the access and the service that we provide for that. If we think about some shortfalls in the current fee-for-service model, you highlighted a couple, but I want to make sure that we hit this directly because it's very important, I think, to patients, consumers, and to our healthcare system. And so we know that insurance premiums are getting higher and higher, and consumers are having a more and more difficult time paying those increasing cost of premiums. Mm-hmm. So a value-based purchasing model, in terms of how we're looking at changing the model, actually helps to manage the cost and therefore manage the premium cost to a consumer that they have to pay. Is that right?
Yeah, under a value-based, we actually would have a target for a total cost of care target. And that really provides an incentive for an organization like North Mississippi Health Services to look at not only the outcomes, but the cost to deliver those outcomes. And it's beneficial for both the organization as well as the patient because we are providing the proper access and the proper delivery of care at the lowest cost. So as soon as that cost comes down, that would enable the premium or the insurance premium that the patient's paying to go down accordingly. Unlike the fee-for-service where the per-click model, every volume is generating additional cost, that continues to increase. But one thing I do want to mention under the fee-for-service model, and I think one of the downfalls of what we've seen over the last several years, is that our costs to actually deliver care to any of the patients have continued to go up. What's causing that? Labor shortages have caused that, supply chain disruption has caused that, inflation's caused that. And what we've seen over the last several years is that the fee-for-service revenue coming in is not keeping pace with the cost to deliver that care. In fact, in 23, when we looked at compounded increases year over year, the gap between what we were bringing in and the cost to deliver that care was about 7 percentage points. So our cost went up 7% more than what we were being paid. That is not sustainable for us as an organization, nor is it sustainable for the people trying to purchase the insurance.
Yeah, so that explains why we want to change the model, the reimbursement model, from what we refer to as the volume-based or fee-for-service model to this value-based model of care. And if we think about value-based models for reimbursement, there are several different types, but we think of it in terms of two different types of value-based payments. One is a shared savings model. Mm-hmm. The other is a at-risk model. And so let's talk about those two different types, and we'll talk about our experience in those two different types. So when you think about the value-based model that has a shared savings component, explain what that means.
Right. On a shared savings component, with the payer or the insurance company, we set a cost target to deliver care for a set population, and that population would be those managed or covered lives under that program. If there were savings, meaning that we were able to deliver the care lower than the target, we as an organization and the providers would get to share in some of those savings. How a full risk model differentiates is that if the target was not met, i.e. the cost to deliver the care was over, we as an organization would have to write a check or basically reimburse the insurance company for that higher cost of care. So there's a higher reward for us. We would still share on the upside in a full risk model. However, we could also have to actually increase our expenses if we were not able to deliver the results we expected. And that would be both in the quality as well as the total cost of care.
Yeah, and we as a system have had experience with both models within value-based, right? So we have experience in a Medicare accountable care organization, which has been a shared savings type model, but in some years at risk. And then we also just recently launched a new relationship with Aetna with their Medicare Advantage product where we're going at risk, as you mentioned earlier. So talk a little bit about our experience in both of those models and why we believe we're prepared to be successful in that, changing the reimbursement model to more of a value-based approach.
Right. The ACO model that you referred to, Shane, is provided by Medicare. We as an organization did not get to negotiate or have any say on what we were being measured against. However, to your point, with our Connected Care Partner Network, our delivery of over 900 providers, we were able to provide results that actually saved Medicare millions of dollars. In fact, over the course of our start in the ACO, we have been able to save over $25 million in total cost of care. The other part of that is back to the shared savings. We were able to share in some of that savings we provided to the tune of about $8 million in total. How the Medicare Advantage plan is very different. First of all, it is full risk, so we had to negotiate with Aetna, and we could share in some upside. However, as I already stated, if we are not able to meet our targets, we potentially would have to write a check back to Aetna. What's also different is it is called a Medicare Advantage plan. These plans oftentimes offer more benefits to the insured, things like wellness benefits and things like eye doctor's appointments and other components that traditional Medicare may not be able to provide. However, that being said, we were able to negotiate key components with it, and the Medicare Advantage plan and the new relationship that we formed with Aetna was effective just beginning in January. So we're at the very start. However, due to our experience with value-based products, our success in that, we have confidence that we'll be able to deliver that quality of care at a lower price point. I also want to mention that we've had a lot of success even in a value-based program with Blue Cross Blue Shield. In fact, in the inaugural year of that value-based program, we were #1 in the state for the Tupelo Hospital, our main campus. And you think about the complexities and the different types of services we provide, that was, I think, a big accomplishment, and once again demonstrates our proficiency in these type of contracts.
Well, you mentioned early on our mission to continuously improve the health of the people in our region.
Right.
So as you think about these different reimbursement models, the fee-for-service versus the value-based model, which one do you think better supports our mission to continuously improve the health of the people in our region?
It's absolutely the value-based care. And if you think about it, as we're incentivized to take care of that population, the value-based programs, and one thing I didn't mention is we're given data. And that data is really demonstrating to us, are the covered lives that we're responsible for, are they taking their medication? Are they doing their wellness visits? Are they having a problem? And through that data, we can surround that patient, we can support that patient, we can ensure that their care is being delivered in the most effective place and hopefully prevent bad outcomes and prevent further complications. So for our patients and us, you can see the benefits compared to the traditional fee-for-service model.
Absolutely. So as I see it, the value-based model better aligns the interest of who's paying for the services, who's providing the services, and the patient who's receiving the services. So those alignment of incentives should lead to better access, higher quality, better patient satisfaction, as well as more effective cost of care or lower cost of care for the individuals involved. And I think one of the things that's not well understood in, say, the Medicare Advantage plans, and thinking about that alignment of interest across the payer, the provider, our health system, and the patients, is that the Medicare Advantage plans are incentivized around not just delivering the care, but also the quality of care, the patient satisfaction with their visits, right? And then, of course, rewarding for lower cost of care. So can you tell me, kind of just thinking about that versus this fee-for-service world that we're in today for the most part, I mean, we don't have that alignment of interest in this fee-for-service environment.
No, we don't have the alignment at all, and in fact, it's not an efficient model. We're not really aware on the fee-for-service in our traditional Medicare, where are they going to get their care? Are they going to a more expensive setting like an ER, or are they actually getting the care that they need in their primary care office? So you think about all the components of a value-based arrangement like the Medicare Advantage plan we have with Aetna. It's really given us all the key components to provide that access, the lower cost of care, and really providing, I think, a better overall experience for the patient. And ultimately, that's what the goal is, what's best for the patient.
Yeah, and we've talked in previous podcasts about access to care, which is part of a great redesign. We've talked about growth in services, which is a part of a great redesign strategy for our system. So this transition or change in the reimbursement model supports both access and growth of our healthcare system, right?
Yeah, I think it absolutely does. And one thing that it does as we continue to show and demonstrate that we can provide that lower cost of care, that will help us direct more and more patients in our community, hopefully, to the services that we offer. That's going to support that growth initiative. And when we talk about the access component, once again, making sure that as through the key elements that we're providing around the population management for those covered lives, making sure that those patients have the access they need to get the care that they need for whatever condition they have. So, those two key components, I think, are really exemplified through the value-based arrangements.
Yeah, and then based on our experience and performance in value-based arrangements in the past, we were attractive. Our network was attractive to Aetna.
Yes.
I mean, for a number of reasons, and that's basically based on our performance across the network. So you mentioned Connected Care Partners, our clinically integrated network. We have the benefit of having largest primary care provider network across our region, all which supports access and allows for growth of services across our entire market, which from a payer standpoint, if they have the opportunity to work with a system like ourselves within a value-based model, it's kind of a no-brainer for them too.
Yeah, I would agree. For access points, or when we look at our network with Connected Care Partners, we look at our locations in both our primary and secondary service area. We look at the breadth of services that we provide here, especially at the Tupelo campus, that we're the only trauma center within a 100-mile radius. We've got the NICU. You really have something that becomes very attractive for the insurance companies because they know that North Mississippi Health Services can provide that access, but more importantly, we have a demonstrated track record of delivering results. And I think that makes us a very attractive partner, but it also gives us the capability to pick who we want to work with. And, finding organizations that we have aligned visions to provide good care to our community is important as well.
Yeah, and I know we touched on this in a previous podcast as we've discussed Medicare Advantage with Wally Davis, but we have focused this change in the reimbursement model on the Medicare Advantage plans and payers in the market. And so let's just kind of touch on why we are initially focused on the Medicare Advantage plans in the marketplace. I'll mention one. You probably have a couple that you might want to mention out there, but we've already touched on in the value-based reimbursement model, there is a clear alignment of interest across the payer, the insurance company, the provider, like our healthcare system, and patients. And that alignment really cuts across access to the right provider, right place, right time, focus on providing or producing the best outcome for a patient, actually promoting better health for patients, patient satisfaction focus, so as they interact with their provider in the clinic or us in the hospital, there's some incentives around improving patient satisfaction, then also lowering cost of care. But you touched on something earlier that I think is important that Medicare Advantage plans offer that aren't typically part of commercial insurance plans, and you mentioned some of those enhanced benefits that support the alignment of incentives.
Right, and I think that makes it attractive for the patient. Things like wellness visits, discounts to do certain fitness activities. Certain plans offer assistance even for things like utility bills and whatnot. So there are some other incentives for people that would, attract them to the Medicare Advantage plans. But I think something else that's really important that we as an organization recognized early on, CMS has stated that they want by 2030, 100% of all Medicare participants to be in value-based contracts. Why is that? Because CMS sees that fee-for-service world is unsustainable as the costs continue to go up. So as they continue to promote it and push it, we building competencies, we aligning with payer partners, we continuing to grow that line of business and being kind of on the front end of that as that book of business continues to grow, I think is in our best interest as well as in the interest of the patients in our community.
And you mentioned one other point earlier about our experience in the Medicare Accountable Care Organization, where we've saved Medicare some $25 million.
Yes.
Now, Medicare returned like $8 million of that back to us in shared savings to us, but still, we produced $25 million in benefit and only got $8 million of that back. And so part of this changing the reimbursement model even more towards that full at-risk arrangement you mentioned earlier is position us so that we're able to capture all of that improvement and benefit that we generate for the patients, most importantly, but also the health plans.
Right, and that sharing of that revenue coming back into us, that helps us continue to, one, make a profit, and two, make a margin so that we continue that critical investment in our people, our services, and our technology. And I know we're here to talk about the R for reimbursement, but that additional revenue is also considered what we call an alternative form of revenue. What is alternative forms of revenue? It's getting revenues or other forms of income into our organization besides the direct fee-for-service patient care model. So once again, our proven track record that we've already demonstrated, continuing to grow this value base, hopefully continue to increase that alternative source of revenue under these models.
That's a great way to summarize to an end here that this changing the reimbursement model really touches and supports access, growth in services, reimbursement, as well as alternative revenue sources. So great summary. So Sharon, thank you for joining me this morning to talk about reimbursement and our effort to change how we're reimbursed for that. And so thank you all for viewing in with us. We would appreciate your feedback on today's segment. There will be a link to a survey that's attached to the podcast show notes. We'd appreciate you taking a few minutes to provide us with your feedback. So thank you for joining us.